Dear colleagues, welcome to the Augenklinik am Neumarkt in Cologne or Köln, Germany. This video shows a new technique of transplant preparation and handling in DMEK. Transplant preparation is one of the most difficult parts of the operation. The risk of losing the transplant may prevent surgeons from performing DMEK at all. With the easy bubble technique, we would like to encourage more surgeons to do their own successful transplant preparation and consequently reduce their dependence on pre-cut tissue. Up to now, we have done several hundred preparations with this technique, which decreased our transplant failure rate from about 30% to less than 5%. The donor cornea is placed endothelial side up on a special holding device. This is connected to a pump to secure that corneoscleral disc is held in place by suction. With a sharp paracentesis knife, a tunnel is created below the iris root and the trabecular meshwork towards the corneal structures. When approaching Schwalbe's line, there is a zone of stronger adherence. It is important to change the instrument to a blunt dilatator to avoid the risk of perforating or getting too deep into the stromal tissue. Schwalbe's line is crossed and the tunnel is continued directly below Descemet's membrane about 2 mm towards the center of the cornea. For the next step, the liquid detachment of Descemet's membrane, we developed this specially designed cannula. It has a conic shape and tapers in diameter towards the tip so that it can compress the tissue at the entrance and the tip can easily be forwarded. The opening of this 27 gauge cannula is facing upwards. The cannula is introduced in the tunnel and we push it slowly forward to avoid any perforation of Descemet's membrane. To avoid too much adherence to the endothelial cells, we covered the silicone sleeve with a little bit of OVD before we applied it. The holding instrument with the silicone cover has two functions. It covers the peripheral parts of the Descemet membrane that may compromise, for example, due to incisions from former cataract operations. And the second function of this holding instrument with the silicone sleeve is to additionally compress the tunnel so that injected fluid cannot escape backwards. The trypan blue is now slowly injected between Descemet's membrane and the stroma until a bubble is created. Now posterior stroma and Descemet membrane are separated and the trypan blue can color Descemet's membrane from the back side without touching the endothelial cells. Suction is stopped and the whole corneoscleral disc is washed in a BSS bath to get rid of all the remnants of the OVD and to let the trypan blue some time to color Descemet's membrane. After a steep learning curve, our success rate is now about 95%. But how's plan B in the other 5% if the preparation is not primarily successful? Let's have a closer look at the most frequent complication, which is a rip of Descemet's membrane. This occurs predominantly in peripheral parts of Descemet's. If recognized early, as in this case, in the preparation process, we advise to create a complete new tunnel from the opposite direction and complete the bubble formation from there. Normally, the weaker periphery of Descemet's membrane, which may be further compromised by former cataract incisions, is covered with a silicone ring. But here in this case, we have experienced a large peripheral tear. Note that about 1/3 of Descemet's is already lifted, which provides sufficient endothelial cells to the recipient's cornea. In a case like this, Descemetorexis can be a better solution. Of course, it is always possible to convert into classical preparation technique. With this technique, you are free to use any trephine with any diameter corresponding to the recipient's corneal diameter. We take the whole corneoscleral disc in a BSS bath and the Descemet roll comes off by its own. So in an ideal case, it is a complete non-touch technique. Now we load the transplant into a cannula It has a big opening to load the transplant and a small opening to inject the transplant through a tunnel into the patient's eye later on. Femtolaser gives you more control about the size of the decimetorexis. Especially of interest when you want to do decimate scaffolding. It is ideal to know that the decimetorexis is slightly smaller than a transplant. We inject the preloaded transplant slowly into the anterior chamber. After correct orientation of the donor button, the anterior chamber maintainer is removed. Sometimes it is difficult to unfold and position the button. In this case, our aspiration technique can help. I use a special 30-gauge cannula to aspirate the transplant and hold it in place. Now it is easy to apply some slight hits with the other hand. After unfolding completely, we fill the anterior chamber with air or SF6 gas. With this technique, our transplant preparation time was reduced by 70% compared to the conventional stripping technique. All newly developed instruments worked fine after a few modifications. So far we have done 170 cases. All steps of the easy DMEK bubble were successfully applied. In 5 cases we need a second tunnel, and in 3 cases we converted to conventional stripping technique. After 3 months, patients increased in best corrected visual acuity on 0.2 logMAR on average. And endothelial cell loss was below 35%. We hope that this technique helps surgeons to gain more confidence in transplant preparating and handling, so that we surgeons can concentrate on the patient and hopefully improve our DMEK results even more.